I'm going to take this opportunity while things are getting going to introduce our next speaker, Dr. Nesanet Mitiku. And I had so much fun reading her CV. I actually flipped through it twice because she has a very distinguished but also interesting background. She received BS in systems engineering from Stanford, and that is really great as a background to go into MS. But also, just to add on to it, an MD from Stanford and a PhD from Stanford in genetics. So, but the interesting part is that even though she, I don't know, part-time jobs or is teaching cadaver dissection and also tutoring in organic chemistry, which sounds really painful to me, but and then doing genetics in mice, she also found time to be Hawaii's Woman of the Year, and also teaching kids, I think, art and cultural issues in Hawaii too. And my personal favorite, Stanford's president of the Ballroom Dance Club. So, Nesanet.
Then we have the music. Thank you for that introduction, Sylvia. It's very nice. So, this is going to be more of a clinical talk, and we're going to talk about multiple sclerosis fundamental concepts. All right, disclosures. I'm funded by the National MS Society. And then the learning objectives for this talk. So we're going to talk about the epidemiology of MS. We're going to talk about the natural history of MS. We're going to look at how to diagnose the disease, and then we're going to look at pathologic features. And this talk is part of a series on CNS demyelinating disorders. So the purpose is to set up a foundation for the next talk, which is going to be on the treatment of MS. So there won't be a lot on treatment here, but when you see the light bulb, that's sort of a point to file away for the next lecture by Dr. Stobie. So multiple sclerosis may have been around or recognized as early as the 1300s. There is anecdotally a story about St. Ludwina of Schiedam in Holland. And at age 15, she was unable to support herself skating and then developed progressive gait ataxia, bilateral vision disturbance that was relatively severe, and then sensory problems, and ultimately became functionally tetraplegic and died at age 53. So fast forward a little bit to a fellow who is relatively the father of MS. There were others who made observations about pathology in MS or some clinical manifestations of MS, but he was the first to thoroughly go through and make correlations between pathological findings and clinical manifestations. And his name is given to the triad of nystagmus, intention tremor, and scanning speech that you see in brainstem disorders in some patients with this disease. But he recognized, obviously, that pathology and clinical manifestations are much broader than that, and categorized what he saw into cerebral, spinal, and mixed cerebrospinal manifestations. He gave the name to this disease as sclerosis en plaques, and the English translation is almost quite literally multiple sclerosis, as we are calling it today. But what he had to look at were these post-mortem samples, and not stained as we often take slides today. And as you can see here, in the white matter, you have multiple lesions, and these were actually tough to the touch and appeared to be scar-like, hence the sclerosed part and the multiplicity. You can see towards the right here his hand-drawn schematics of some of the things that he saw. He also recognized that cognition was importantly affected in MS, and this is one of the things he wrote. There is marked enfeeblement of the memory, conceptions are formed slowly, the intellectual and emotional faculties are blunted in their totality. So it wasn't just physical, there were cognitive aspects. And in describing vision, he also described a very important physiologic aspect of MS that we appreciate to a greater degree today. So he wrote amblyopia is a persistent and frequent symptom of cerebrospinal disseminated sclerosis, but it rarely issues in complete blindness. So the phenotype was not as severe as you might expect from what you see and the extent or the territory of the pathology. Patches of sclerosis have been found after death occupying the whole thickness of the optic nerve in cases where during life, an enfeeblement of sight simply had been noted. And he goes on to state that the nerve tubes have not been disrupted, but rather stripped of their medullary sheaths. So axonal preservation in the setting of demyelination. So he's highlighting that when you don't have axonal transection, you have the potential to have relative preservation of function. Not normal, but not completely disrupted. It was a nice concept. So to summarize sort of the knowledge at his time, so multiple sclerosis as a multifocal white matter disease with dysfunction related to areas of scarred plaques and incomplete dysfunction when you have demyelination with intact axons. And there are, of course, both physical and cognitive manifestations. So then we fast forward to the present time, and we're going to visit the epidemiology of the disease. And this is LP640 Lamborghini, gets up to about 200 miles per hour. So MS, the prevalence, more than 450,000 individuals in the US with this disease, probably underestimated there. About 2.5 million individuals worldwide. Women outnumber men, and it's now estimated to be about 4 to 1. We used to say 2 to 1, 2.5 to 1. This gender discrepancy has been increasing over time, and that's a subject of great interest, yet unknown why that is. Onset is usually between 15 and 45 years of age. About 85% present with a relapsing, remitting course. So that means that you have episodic neurologic dysfunction, and then you have some amount of recovery, but the extent is relatively uncertain. About 50% will get nearly everything they had before the onset of the relapse with each episode. And it's the most common non-traumatic cause of disability in young persons. And the geographic distribution of this disease is pretty interesting. So here you see that areas that are in red are high risk. Areas that are in yellow are low risk. And those span closely around the equator. And then in the regions between these low risk and high risk areas, you have a gradient area of risk, and those are indicated in green, as you see in Australia here and the lower US there. But how about closer to home in the Northwest? What do things look like? So the rate of MS is about 1 in 500 here in Washington State. That's twice the national average. So again, this is a disease that affects folks 15 to 45 years of age, and this is a critical time window in life. So it's a time at which people are usually raising a family or putting together a family. Towards the end of that age range, you're trying to get kids into college, maybe. And it's also a window in which individuals are in their peak earning years. And this disease carries with it a 70% unemployment rate. So this financial nest egg that you're supposed to be putting together for later in life, that you're supposed to be supporting your kids with and so on, this is a big problem for individuals with MS. And there are implications for the rest of the family as well, because they end up taking on a caregiver role. And it's a very expensive disease, so the impact on the family is expensive. The cost, not even thinking about the disease modifying.
Is that 1 in 500 women or 1 in 500
overall, men and women? Mm-hmm.
So there's a higher risk for women?
There is a higher risk for women. And it's a very expensive disease. So even if you're not considering the cost of disease-modifying therapies, the cost of the disease is about $34,000 per year. Now add on to that the cost of disease-modifying therapies, which are $40,000 to $50,000 a year. Now patients don't usually see the whole amount of that cost, but that is part of the cost to the system. So what are the most common presenting symptoms of MS? So sensory symptoms top the list. If you take all comers, about 40% present with a sensory kind of symptom. Motor is up next, with that total of all comers being approximately 20%. If you look at individuals that are greater than 30 years old, then sensory and motor become approximately even at 30%. And then optic neuritis, limb ataxia, and diplopia come in at lower rates. But MS can, present any which way it pleases. It really matters where the territory that's hit is. But this is just sort of statistically what happens. We have 4 widely recognized clinical subtypes, and these are arrived at by clinician consensus. So it's not that we had some kind of pathological analysis that led to this, but they have become relatively useful. So the most common manifestation is relapsing remitting, and here we go, which is the first one shown there. And so at the time of this mouse is not disease onset, you have an increase in disability. So the y-axis indicates level of disability, and that level is sustained for some time, and then there's a return to baseline, or somewhere near baseline, maybe not quite back to that. But the important distinction is that in between relapses, so here relapse number 1 and relapse number 2, the intervening level of disability does not change. This is in contrast to secondary progressive MS, which a large fraction of folks that start out with relapsing remitting MS will transition into. So if you look at secondary progressive MS, over here you have a relapse, another relapse, and maybe you had even a level of disability in between those two, but sometime after that you transition to a phase where you're gradually accumulating more disability with time. And that doesn't preclude you from having relapses. It's just that once you've had a relapse, then you continue to accumulate some more disability. Primary progressive MS is distinguished from others in that from the get-go, you're progressively accumulating disability. You may or may not have any relapses. If you do have relapses in that course, then you would be in that progressive relapsing category at the bottom of this. So what happens when MS does not get treated? It's hard to get this kind of data anymore, but they could get it before we had disease-modifying therapies available. So untreated, in 10 to 15 years, 50% of folks with relapsing remitting MS transition into secondary progressive MS. And 50% of folks that have relapsing remitting MS will need a cane in that time frame. If you fast forward another 15 years or so, 10 to 15 years from there, 90% of folks will transition into secondary progressive MS. And if you go yet another 5 years from there, 83% need a cane. And 34% of folks may spend some of their time bedbound. Obviously not all of them, those two figures. So if we look at a representative clinical course for a patient that starts out with relapsing remitting MS, we're going to look at this different ways. So at the bottom here we have MRI activity. So at the time of first clinical presentation, you have some lesions that you acquire in the course of that relapse. However, you've been acquiring some lesions. This is just not working very well. Acquiring some lesions well before that time here. It's only that we're, as clinicians, not aware of it. And over time, you have more and more MRI activity and increase the level of your disease burden acquisition, and that levels over time. The green, so the green curve indicates each individual clinical relapse. And so you have the first episode here, and you'll note that there are about 5 relapses in this window here in the relapsing remitting phase, but you've had a great number of additional MRI activity episodes. And when you look at serial MRI studies, as they've done at Queen's Square, it can actually be 10 to 15 episodes of MRI incidences relative to the number of clinical episodes that you see in a patient. So the disease activity is higher than you would see by just following the patient clinically. Another thing to note is this red curve here, which represents brain volume, over time this is decreasing, and towards the secondary progressive phase it tends to increase much more quickly. So with our current disease-modifying treatments, we're often catching folks here at the first or second relapse. The McDonald criteria, which we'll talk about in a little bit, are fashioned around the concept of trying to determine whether or not there have been 2 clinical events, even if you haven't had 2 clinical overt manifestations in a patient that they could tell you about. Ideally, we catch people before you have even the first clinical relapse and prevent the rest of the disease from happening. But right now where we are is we're trying to prevent people progressing into secondary progressive MS. All right. So imaging is quite important in the diagnosis and the management of multiple sclerosis. And so we're going to head into that section next. General characteristics of MS lesions. They are asymmetrically distributed. They're ovoid in morphology. They're larger than 1 by 1 by 3 millimeters. And they can be enhancing or non-enhancing. So the enhancing component gives us a sense of the lifespan of that lesion. So if it's enhancing, it's occurred within 4 to 6 weeks. Most lesions will initially enhance. We know that from serial MRI data, monthly MRI data. And they may leave a lasting T2 hyperintense or T1 hypo intense imprint on the brain. The most clinically useful sequences in MS are the T2 flare sequence where CSF is suppressed, T1 without GAD, and T1 with gadolinium. So looking at a couple of scans here. So as you can see, this is an axial view. There are a number of ovoid lesions near the ventricles. Some of them appear to be extending radially away from the ventricles, likely reflecting perivenular spaces that are inflamed. If we look at a sagittal image, also a T2 flare image, we see a similar phenomenon, ovoid type lesions with some extension, and these are the Dawson's fingers that are very characteristic of the disease. And again, they represent perivascular inflammation, these spaces that are available to the inflammatory cells. You can also get lesions in the spinal cord, and here in MS they should be less than 2 spinal segments long. If they're longer than that, you have to think about another diagnosis, or a couple of diagnoses actually. So you see here that there's an ovoid lesion in the posterior aspect of the cord at C2. But MS lesions are anything but static. As I mentioned, it can be 10 to 15 to 1 in terms of the ratio between the lesions that appear and the actual patient clinical picture. So this is a video I'd like you to watch. This top lesion here, and the arrow won't stay. If you just saw that MRI at month 8, you might wonder if that lesion had existed. I have another lesion here that's been stable throughout the entire video. One more time. If you look up here, it's a lesion that appears and disappears. Maybe comes back and it's gone. So if you're getting MRI once a year, once every 2 years, which is not unusual in taking care of MS patients, you may not capture the complete picture of disease activity. Also note that the lesions are asynchronous, so there appears to be some kind of local control on lesion formation and resolution, if there indeed is resolution for a particular lesion. We don't exactly know how that happens yet. You may get an imprint, as we saw, may resolve completely. So I already made that point. T1 sequences are also quite useful, and they give us a sense of whether or not there are black holes, and those are associated with axon loss. So we talked about Charcot's observations and how there was preservation of function when you had demyelination but not axonal transection, but you do also get axonal transection and loss. There are some more advanced techniques, MR spectroscopy, looking at the balance of different molecules that can quantify this a little bit in a more sophisticated fashion, but that gives you a sense. T1 with gadolinium, so again, the contrast enhancement will give you a sense of how long a lesion has been around. And this will be important when you're trying to diagnose MS in someone who presents to you for the first time. One other thing that has been getting a little bit more recognition recently is that brain atrophy is a big problem in MS. And this is another video, and it's serial monthly MRIs over a 3-month period, but it's quite striking. You can see that the ventricles are getting larger, but the sulci are also getting larger peripherally. These people are losing a lot of brain tissue. So diagnosis of MS, you do need a plausible clinical story that's not readily explained by another cause. Neurologic dysfunction should be present for more than 24 hours, and there shouldn't be any fever or infection which could induce a pseudo-attack via an UTOFs-like phenomenon. They should also not be saying that I was out in 110-degree weather and for an hour and then had trouble walking. That would be a pseudo-attack. There's a characteristic lesion distribution in the central nervous system, and the criteria that we're going to review reflect this. You also want to make sure that there is dissemination in time and dissemination in space, and we'll also review that. So there have been numerous systems for diagnosing MS in the past, the majority of which have been most friendly for research purposes. But there was a drive to make the criteria more clinically accessible, so you don't have to be an imaging expert, as well as to allow for making a much earlier diagnosis, because earlier treatment may allow for earlier diagnosis may allow for earlier treatment and better outcomes. So the first concept of dissemination in space. So you have to have at least one lesion in at least 2 of 4 CNS areas, and these areas reflect the distribution of lesions in MS generally. So periventricular, juxtacortical, infratentorial, and spinal cord lesions. But if a lesion is symptomatic, you need to exclude it from the overall count. So this part is going to be interactive. So we have a 26-year-old woman who presents with 1 week of diplopia and an inability to fully adduct one eye. She has 2 periventricular lesions and 1 enhancing brainstem lesion. Does she meet DIS criteria? Have a yes.
Yes. Distributed in space, not distributed in time.
Correct. Or is that your answer? That it's distributed in space and not in time? So
No.
So she's only got 1 brainstem lesion. It's enhancing, and she's got an MLF problem. So we can't count that lesion. And then she's got 2 periventricular lesions left. So which means
That's a no.
that's
Why are 2 periventricular lesions 2 lesions?
they are 2 lesions. It's just that, so let's go.
Criteria says it's at 2 places.
Right. So she could have.
Separated, it's in 2 places. They're both periventricular.
So they have to be within. They have to be distributed across categories rather than just being separate from each other.
Can I
I've never heard that explained that way before. Can I ask, what's the reason for ignoring the current acute lesion? Why would one do that?
So so the general concept of McDonald criteria is that you want to know that you have two concrete clinical episodes. So you know that that lesion is associated with the one that you are seeing. So you're seeing that she has an MLF lesion and she has that problem, and the brainstem lesion verifies that. But you were looking for one more. So I want to know.
Clinical event.
Correct. Right. Something that will suggest another clinical event that's not associated with this one. So what's interesting about this is, so say she has an enhancing frontal lesion, she doesn't have any symptoms that would reflect that. It's possible somehow that she had two simultaneous lesions, so this brainstem and that one developed at the same time, and they're part of the same episode, right? So in some senses, these criteria don't make a whole lot of sense, but it's also possible that this MLF lesion, we know it's maybe about 1 week, maybe about 2 weeks old, right? So some time to evolve. It's also possible that that one is 29 days old and just at the brink of being detected. So we really can more closely identify the timing of the MLF lesion, but this other frontal lesion that she could have, it's harder to pinpoint as being in the same exact time window.
The McDonald criteria didn't exclude clinical lesions.
Yeah, the 2010, that was a change from 2005 to 2010. Okay. Yeah.
So this is a very useful exercise. I would have to say, if you were a clinician and you had this patient and you were down in the neuroradiology suite looking at the film, and you saw two very large and very convincing periventricular lesions in a 26-year-old woman with this clinical picture, you would not be hesitant, I think, to put the picture together as MS. Very likely, independent of this criteria. So this is a very good set of criteria for investigative work, precisely defined endpoints, rules that are very tight. But I think in managing this patient, Eric would have been very suspicious of MS.
Right, and you just wouldn't have a definite, and there's something called
clinically isolated syndrome.
Yeah, and you might treat that as well anyway.
And with periventricular lesions, what is it, 85% chance of going on to MS in the next 5 years or something? I mean, having two clinical events.
Yeah.
I have a question. So what would happen if you amazed the woman 2 months later and you saw the two periventricular and this one brainstem lesion? Would she then fit the criteria?
So she didn't have any new lesions apart from these?
Yes.
No, she wouldn't meet criteria. But if she, let's work through the rest of these, because I think it'll get a little bit more clear, and if it doesn't, then we'll do some more. So if she had one periventricular, one juxtacortical, and one brainstem lesion, so then she has now two different lesions other than the symptomatic brainstem lesion at this time, and that would give her dissemination in space. So dissemination in time criteria. So two different ways to get that. Well, 3 different ways. So if you have 2 discrete clinical episodes that you can verify on your exam, you already have dissemination in time. Just to sort of drive home the point that these MRI criteria are to help you when you don't have that sort of arsenal. So one way is to have a new T2 enhancing lesion on a follow-up MRI, and this kind of is getting towards your question. So if you get another MRI in 2 months and she has a new lesion, she gets dissemination in time. It doesn't have to be enhancing it at that point. But if she had a simultaneous enhancing lesion in another location than the brainstem at the time you did the initial MRI, she would meet the dissemination in time criteria as well. So it does seem like splitting little hairs, but it does allow you, this can allow you to make the diagnosis a lot faster. And as you'll see later, it can allow you to make a difference in outcomes. So dissemination in time example. So another cooperative problem. So we have a 44-year-old gentleman who reports transient 1-month duration reduction in left visual acuity that happened 5 years ago. Then 2 months ago he developed some left lower extremity weakness, and this is getting better. On your exam, everything is normal except you have a low contrast vision chart, and he does poorly on that. He's got 4 out of 5 left quadriceps strength, and he has a brisk left patellar reflex. What do you think? Would you call MS on this person without doing any imaging?
Feel free to call in the residents. That's what they're there for.
All right, in the back.
I'm still thinking the image, because there's a lot of different things that can cause, let's see, he's got like left-sided weakness and I don't know, maybe some reduction in vision. I still don't know if it's a different process now, so
Mhm.
there's strokes or.
Yeah. Okay. And that's reasonable. Do you want to know anything about his history? That might help you about the stroke question, not stroke question. Sure. Yeah, so if you were a diabetic individual, had hypertension. So the eye part too, right? He might have retinopathy, or he might have had ischemic optic neuropathy as well as possible. Anybody else? Would anybody else call MS without imaging? Or she wouldn't, which I think is reasonable. Okay. All right, so do you think if you're just thinking about dissemination in time, would you call it? Okay. So now take the same guy, right, and you forgot to do his reflexes. And he's got 4 out of 5 left quadriceps. And then near the end of his visit, he says, I had some needle exam about a month ago, and he's got fibs and positive sharp waves and adductor longus and rectus femoris. So it's looking like he may have a radiculopathy. So now does he have dissemination in time?
Well, he's got symptoms that are disseminated in time. If that's
But are they relevant?
Then the answer is yes. Obviously, you're presenting us a scenario now which should take us in a different clinical direction.
Mm-hmm. Go ahead.
But I don't think we should be looking dissemination in time and space as a face value. The criteria, I think, involves at the last line as in absence of any other explanation to those symptoms, then you make the diagnosis of MS. If you have explanation of that symptom based on other medical condition, then it's not MS.
Well, you only have explanation for one symptom, right? So you still have to keep in mind that he had this left visual acuity. He might tell you I had pain behind that eye too, and so you're in a situation where you still have to think about the global picture. And then you do get an MRI of the brain and spinal cord, and he has numerous T2 hyperintense periventricular lesions and one small enhancing posterior cord lesion at C3. Dissemination in time with consideration of MS. I'm seeing yes on the back row. Yes. Yeah, that's reasonable because you can't explain his symptoms with the C3 lesion and it's enhancing. Does he have MS by McDonald criteria?
Yes.
Yeah. Okay, so primary progressive MS is treated a little differently from the rest of them. So criteria are that you have 1 year of disease progression with progression from onset, and that can be either prospective or retrospective, and at least 2 of the following, that you have dissemination in space in the brain, and 2 of the following, and separately dissemination of in space in the spinal cord, and the third thing that you could use is having positive oligoclonal bands or an elevated IgG index. Just need 2 of those 3. But primary progressive is a lot more challenging because the probability that you'll see enhancing lesions is quite a bit lower. And what about clinically isolated syndrome? So it's a single clinical episode that's suggestive of MS, but either a dissemination in time or a dissemination in space criteria are not met. And you probably have this really good gut feeling that it's going to be MS. And these people are at significant risk. So if you look at all comers, about 45% will convert into clinically definite MS. If the age is less than 30 years old, then that risk is more like 60%. If they happen to have an enhancing lesion and they have multiple other lesions that are or not enhancing, then the risk is 75%. So it's appreciable. So as in the previous case where you would have treated, potentially that's the kind of picture. So isolated optic neuritis carries a lower risk of conversion if the baseline MRI is clean. So if all the person has is optic neuritis and no brain or spinal cord lesions. The treatment of CIS could delay and maybe even prevent conversion to MS. So the first line, a lot of the first line therapeutics for MS have been tested in CIS, and they range a 30 to 50% reduction conversion rate over 2 to 5 years. I'm not going to cover all the details of the medications because that will be done by Dr. Stobie, but you have, if you're able to recognize CIS, you have potential for earlier diagnosis, earlier treatment, and better outcomes, at least on this time frame. And then we have this thing called the radiologically isolated syndrome, which is kind of a very...
May I ask if you would consider treating someone with isolated optic neuritis?
I would think about it.
Age
Yeah.
30?
Yeah.
Could you repeat the question?
Oh, so the question was, would you treat isolated optic neuritis? And my
But
answer
the
is
insurance may not
yes.
pay for it.
You have to make an argument.
Yeah, I'd be on the fence. I don't know how the rest of the MS community feels about that.
That's on the MRI.
So if the
So if
MRI
you
was
saw-
normal,
Well, then you have according to the optic neuritis treatment trial, you have a 14% chance in 5 years of a second event. So I don't think those odds. I'd wait.
Would you? I have a let's follow up question. Would you? How quickly would you get the next MRI?
6 months.
But I think what you're quoting, treating with steroids, as opposed to what I had never thought of until Bruce mentioned it, but what about treating these people with an isolated optic neuritis with a disease-modifying agent?
that's what she's talking about.
Mhm.
That's what she's
Mhm.
talking
But aren't the outcomes going to be different? One treatment versus another.
Quite possibly.
I'm unclear about that. That's what I'm asking about.
Yeah, quite possibly. And I guess I would also aggressively image the spine because you're also at risk for NMO too. So.
I have a question. So when you say the isolated optic neuritis and the MRI is clean, you mean to say that even the optic nerve doesn't show any signs of enhancement?
So the question is, if you say isolated optic neuritis, does this mean that the optic nerve doesn't show any sign of enhancement? You may. So when you have optic neuritis, you may or may not see any evidence of enhancement or even T2 signal on the MRI. There are other ways at getting at that information. So you could do visual evoke potentials. That would be a way of getting an objective assessment. It's a difficult test to do, but it can be done. You could also get OCT, so optical coherence tomography, and that could also give you a sense. But you might not see that on MRI. It's possible.
So, go ahead.
Increasing lesion load and odd ratio went down
Where are
in the
you?
last two.
Well, so it's not even significant. And look how wide, I'm pointing with my finger instead of this. Look how wide the confidence interval is here, you know. So your confidence in this value is very low. Yeah. Well, also the confidence interval too is really. So you shouldn't attribute any weight to the actual number there.
So is this, let me make sure I understand this sentence in terms of whether it's plural or singular. In patients with an asymptomatic spinal cord lesion?
It's a typo.
Or is it in patients with asymptomatic spinal cord lesions?
So if you have an
Plural?
asymptomatic lesion, that will hold. If you have more than one, it will also hold, but it just needs to be one. Does that make sense? That's a
So,
typo.
Another way of saying that is that the idiopathic, if you will, variant of transverse myelitis that may not have reached clinical presentation. Someone has something, neurotropic virus, whatever it might be, and winds up with a small residual lesion in the spinal cord. Never had any clinical symptoms that they can remember clearly. And for whatever reason, because they fell at work,
They get an MRI.
MRI of their spine, and you see a single lesion. 85% of those people roughly will go on.
Well, it's of all comers, right? So you're also looking at 16% that won't, right? So potentially the 16% in this series may have been folks that were exactly like that. I mean, so you're painting a very specific individual, right? And this is a population, but that would confound this. I mean, that would be potentially included in this.
Yes, I mean, that would be, I mean, I'm just marveling at the idea that that's only 16%. I would have certainly guessed based on my own clinical experience that it was sizably higher than that. But I can't refute the data from the study. I don't know the study. Where's it from? Is this a
UCSF.
Asian study?
UCSF.
UCSF.
I think Darren Okuda collects MRIs from that people get for other reasons, and the question is whether they have MS. So he gets all these MRIs sent from around the country to him, but these are all people who are completely asymptomatic. So I would wonder what the numbers, the N size.
So yeah, the total N that they looked at was maybe 121, and the ones that were just with a spinal cord lesion was something like 76, 77. I mean, so it's not huge. Yeah.
I mean, I was trying to think in 20 years if I've ever seen a spinal cord lesion that was asymptomatic, but it's interesting.
Yeah. It's something certainly to think about. So there are a number of MS mimics, and as you pointed out earlier, you have to be relatively sure that it's not something else. And the one that I want to talk about, because you can do some harm not just by not diagnosing it, but by treating it like you would MS potentially, is neuromyelitis optica. So it's also called de Vic's disease. So the treatment that's potentially harmful is interferon. It can make them worse. NMO is a combination of optic neuritis and longitudinally extensive transverse myelitis. So you need to span at least 3 spinal levels. And it's associated with an antibody that attacks aquaporin 4, and this localizes to astrocytic end feet. And when you damage the astrocytes, you get local dysregulation of ions, and you get myelin problems, and then you get also problems with the axons themselves. And it really can be quite spectacularly degenerative. There is an NMO IgG test, or an anti-aquaporin 4 test, that has 75% sensitivity. It's not particularly sensitive, but when you see it, then you should really pay attention to it. So disability in this disease is can be acquired rapidly and occurs in a stepwise fashion. And every time you have a relapse, you're at big risk for having a large loss of functions. It's something to keep an eye on. Do not treat these people with interferon. And so this is just an example of a longitudinally extensive lesion, and you can see that this starts really at the border of C3, C4, and it extends down towards C7 here. So. In summary, so MS is a dynamic, multifocal, often episodic, disabling neurologic disease. It strikes during the most productive years, so it can be very devastating, disabling, and costly. MRI is extremely useful, allows for earlier recognition and treatment, example BCIS. It allows for risk assessment even in the absence of symptoms, example BRIS. But it will underestimate disease activity at the practical frequency with which we obtain MRIs. Pathology in brief. So looking at inflammation, in the parenchyma. The main point, I'm running out of time, so the main point here is to point out to you the macrophages here, which are laden with myelin. This is a slide that has been stained for PLP, which is a major constituent of myelin, and these macrophages are taking it up as they're clearing out lesion debris. But perhaps more distinctly here is demonstrated perivascular inflammation. Here, RBCs mark the position of the blood vessel, and you see that there are many cytoplasm-poor, strongly nuclear staining small cells forming a rim around the blood vessel. And a lot of these are going to be lymphocytes, which play a strong role in MS. But also I want you to notice these black arrows here. That's a healthy neuron, so the chromatin is relatively open. Not too far away from it here you have a neuron here with a dark, relatively closed nucleus and a cytoplasm that's more eosinophilic, and that neuron is not doing very well. Also present in these lesions are hypertrophic astrocytes, and the white open arrows here show those cells. For a long time, MS was thought to be a white matter disease, but more recent studies have certainly demonstrated that cortical demyelination is quite prevalent, and it may actually occur earlier than the other lesion distributions. And you can see this kind of pathology on 7T MRIs, but those have research application, not so much clinical application at this time. And they're relatively uncomfortable for people to go through too. And then to hammer into the concept of axonal transection, this is from Bruce Trapp's group. What you have here is a confocal image of brain parenchyma, and in red you have myelin. It's an antibody against myelin-basic protein that has then seen a secondary antibody that's red fluorescent, and in green you have axons that have been labeled for neurofilament H. And what you can see where the arrowheads are areas in which myelin has been denuded. These may actually be intranodal or quite clean. And then you also see this large bleb here, and this is where an axon has been transected. And sometimes you can even see T cells literally cutting through, moving through an axon, if you've seen any videos of this. So MS is demyelinating and axonal. MS pathology summary. So it's a demyelinating disease. You have denuded axons. It's also an axonal disease. We've seen axonal blebs. It can involve neuronal death. I've showed you some condensed nuclei in pathology. We also know that there's a great amount of atrophy in the disease, so cells are being lost. It's both a cortical and a white matter disease. It's highly inflammatory. There are lymphocytes, macrophages, reactive astrocytes, and others, such as microglia. Perivascular inflammation is particularly pronounced. And all of these points are an opportunity for intervention, though we don't have agents for all of these items. So if we could support axons, if we could support myelinating cells, oligodendroglia, they're precursors, if we could support neurons, so if we had repair or neuroprotective agents, this would be a good thing. What we do largely have are agents that work on the inflammatory system in different ways. So some of them keep the inflammatory cells out of the CNS at the blood vessel level. Some of them trap them in lymphocytes. And then there are agents that sort of switch the inflammatory milieu to more of a regulatory rather than a pathologic sort of a phenotype. But you will hear more about this with Dr. Gary Stobbe. So with that, the future of MS is relatively bright. We have a lot of opportunities. Young researchers, residents that are in this room, so hopefully you're interested in following that kind of a path and opening up for any other questions.
The slide you showed in the beginning where as your disease becomes more progressive, you're seeing less lesions, less MRI lesions, less gadolinium enhancing lesions. So What, and if you look at it in terms of an inflammatory as well as a neurodegenerative disease, what do you think turns off the inflammatory response?
Oh, that's interesting. So I guess I would not say that the inflammatory response is necessarily turned off. And I may be in a minority in saying this. I would say that the blood-brain barrier breaching has been turned off. So I don't equate gadolinium enhancement with inflammation cessation. I think the nature of inflammation may be changing. Certainly the organization of inflammation in the brain is also changing. The cells are spreading out more. They're not as focal in terms of these inflammatory cells.
But also the drugs don't work as well.
That's true, but they also may not get in as well, potentially because of the change in the blood-brain barrier. It's possible that the inflammation itself is allowing for better, or the perivascular inflammation and leakiness of the blood-brain barrier is allowing for better access. So there are different possibilities, potentially. I think there's a group at Harvard, so they have been looking at different subtypes and looking at antibody reactivities in the brain, primary progressive MS versus relapsing remitting MS versus secondary progressive MS. And I think there's a little bit of an argument that somehow heat shock proteins are changing in some fashion, that may have some relevance as to the transition between relapsing remitting and secondary progressive and so on. But it's all very preliminary, and it wasn't certainly a comprehensive exploration of all proteins that may be expressed in the brain. It was a selection of a library. So it's, yeah.
Treatment for NMO, is it still Imuran twice daily?
So Imuran is a possibility with or without prednisone. Rituxan is also possibilities. Cyclophosphamide is also.
Is this a lifelong treatment?
Make sure to repeat the question.
Oh, sorry. The question was whether or not Imuran was the treatment for neuromyelitis optica. And so the answer was that there are other options as well. So in addition to azathioprine, you may couple it with prednisone, you may not. Methotrexate, Cytoxan, rituximab. And I think their variable durations of treatment depends really on what the clinical course ends up looking like.
The earlier talk was on stress and opioid receptors, and there were some remarks about other disorders that could affect stress because of degeneration. Do you see stress as a significant issue in the relapsing of MS? Someone who is stressed all the time and can't cope with it, is that person more risk for having relapse?
That's an interesting question. So the traditional thought on that is that stress would be a risk factor for MS. There have been thoughts because of, so in Israel, I think, in the context of some sort of a war event, there was no increase in the relapse rate, and that's supposed to be a stressful event. But then you also have a country, where every apartment has a bomb shelter, sort of a room attached to it. So the baseline stress levels are probably relatively high. So the answer is I don't have a very concrete answer for you. Oh, okay. Questions up here. So why do you think the geographic distribution of MS doesn't continue along the east-west axis in the northern southern hemisphere at a certain distance away from the equator? It seems that North America, Europe, Australia islands, New Zealand are islands, are affected, but why are South America, Russia, and Asia seemingly spared? Is it relating to reporting bias, genetic differences, viral exposure? It's a great question. I think if you go back to that.
Geography test.
So back to this picture where your question stems from. So some of this is unknown. So probable high risk, purple, where Russia and sort of that very cold region of the world is there. Sampling is not fantastic. So this, and you should also note that this is from, it's in the 1960s. I don't think you can read it still. You can read it very well right now. So part of it is sampling. So as you go to some of these conferences, you see these smaller countries reporting, oh, we have X number of cases of MS now here, and is that because there isn't clinical recognition, or is that because the disease wasn't there? It's really hard to comment on that. But the commenting on the equatorial part of your question, there are different things that can exhibit some kind of regional variability. So something that is often raised is this related to UV exposure, or is this related to vitamin D potentially, which is also correlates a little bit with what the UV pattern is. Other things, so can it be genetic in nature? We're not so genetically isolated anymore in regions of the world, so that's less likely to explain that. And then another option is potentially infectious, and that's actually very appealing. You can have viruses that have regional predilections. And certainly if you look at the story of the Faroe Islands, and they were sort of this, I wasn't actually going to do this, but I actually do have a slide on Faroe Islands. All right, so we have the Faroe Islands here, and they're actually in a hotbed of MS all around them. The people who live there are of Norwegian ancestry, and Norway has a high rate of MS. But they're a collection of isolated coastal villages, so you can't just go from one village and part of one island and walk over to the other side of the island. The terrain is very high in the center of these islands. So what happened, prior to 1943, there were no cases of MS, and then you had an epidemic of MS. And this happened nearly simultaneously in multiple villages on different islands. So it couldn't have been that these people were spreading it amongst themselves, whatever it was. But what it did correlate with was with British troop encampments, and those guys were getting around, right? They had boats, they were getting around. And this epidemic nature of onset with this new exposure to British troops was highly suggestible of a transmissible agent. So to answer that question, could this be viral? That is a potential, and this is a very interesting population within which to study that.
How do you think, and just to tag on to that, how do you think the change in female-to-male ratio from 2 to 1 to 4 to 1 over the last 30 years or so, it fits in with that viral possibility?
Oh, that's interesting. So if you had some kind of tropism potentially, like there was a gender tropism for the virus, that's a possibility. It could also be something else, environmental, has nothing to do with it.
It's toxic, thanks to the British.
But the thing is, it's interesting that he thinks that, because there are these waves. So in his paper, they were separated by maybe a decade or so. So are there toxic waves once the British are gone? It's something that actually remained and was dormant in some fashion.
3 years.
Yeah. So
You know how those Brits are.
No, I don't actually.
I'll tell you sometime.
I'm going to add something to some of that for you. There is something called the Circumpolar Neurological Society, which is strongly attended in the Scandinavian countries and in Alaska, which is where I had contact with it. And the information that's shared in that group is that there is a lot of MS in northern Russia. But there are not a lot of neurologists. There's not a lot of information gathering, especially more recently. And there is also lots of MS in Norway and Finland, and yet, they're in blank on your diagram. I think there's a lot of data that's missing from that map. And I can say nothing about the southern end, but there's plenty of it in the northern end, and there's a lot of it in Alaska. But you have to be careful who you ask. because there is none of it in the Alaska Native population, especially in the Eskimos. So when you talk about the Alaskan MS population, it is almost exclusively in the Caucasian population. And there is very little in the Indian American, North American natives that aren't Eskimos. There is very little, and that's only in those with mixed heritage. So there's a lot of epidemiology that's still there to be studied, but there's plenty of it in the northern part of the northern hemisphere, including Canada. But again, there are very few neurologists in northern Canada, so you don't have good data gathering.
Great, thank you.
Thank you very much.